A 48 years old right-hand dominant mechanic present for evolution of right side, ulnar-sided wrist pain. 2 weeks earlier, he had slipped in his shop and landed on a dorsiflex wrist. The primary impact was a hypothenar eminence. Subsequently, he developed intermittent ulnar-sided wrist pain exacerbated by radial and ulnar deviation. Grip strength is diminished and he felt his wrist give away when torquing heavy tools. The symptoms reduces his work productivity and preventing him from particularly in his weekly bowling leagues. Now, if we just think about the history, the differential diagnosis can be non-dissociative mid-carpal instability, lunotriquetral instability, ulnar impaction syndrome, triangular fibrocartilage complex injury, piezotriquetral injury, or extensor carpi ulnaris subluxation. You further move on to examine this patient. No wrist swelling or obvious deformity is noted. There is pointedness dorsally over the triquetrum. Range of motion was diminished in all planes. A painful clunk was palpable in the radial ulnar deviation. Compression of the triquetrum with the radial direction force elicits pain. Excessive laxity is present at the lunotriquetral ballotment when compared with the other side. Grip strength is reduced by 20% compared with the contralateral side, which is the non-dominant side, and he is neurovascular intact. As indicated, you proceed with radiographs. EP, lateral and oblique radiograph of the wrist are normal. An arthrogram is requested. A relative malalignment between the lunate and triquetrum may be apparent on the lateral radiograph. Bisectors of the lunate and the triquetrum intersect to form a lunotriquetral angle, which is normally 14 degrees. Patient with lunotriquetral dissociation will exhibit a negative angle, means value of minus 16 degrees. A volar intercalated instability pattern is present in chronic cases. Radial deviation and clench-pinch anterior-posterior views can be useful. Palmar flexion of the scaphoid and lunate without movement of the triquetrum confirms the loss of proximal row integrity. Arthrography is a useful imaging tool for lunotriquetral instability. Passage of dye through the lunotriquetral space documents the presence of perforation, tear, or dissociation. Age-related lunotriquetral perforations and tears have been frequently demonstrated in asymptomatic individuals. Therefore, arthrographic finding requires a clinical correlation. Bone scans, CAT scan, and MRI have limited utility in the setting of lunotriquetral instability. Standoff MRI for lunotriquetral instability have not been devised yet. As you have noticed that there are multiple differential diagnoses of ulnar side wrist pain. However, a history of specific injury with subsequent instability and clunking during radial ulnar deviation suggests relatively few diagnoses. These include lunotriquetral instability, non-dissociative mid-carpal instability, TFCC injury, ulnar impaction syndrome, piezotriquetral injury, and ECU subluxation. Let's try to deep down access these differentials. A mid-carpal instability often produces a painful clunk with ulnar deviation, but anecdotal trauma is rarely reported. Provocative lunotriquetral maneuvers are negative. A catch-up clunk may be demonstrable during the movement of a loaded wrist from radial to ulnar deviation position, resulting in sudden extension of the lunate and scaphoid in this condition, as joint contact forces them to catch up to the already extended triquetrum. Sign radiography is useful to examine the synchronicity of proximal row kinetics to differentiate mid-carpal from lunotriquetral instability, and the latter demonstrating the clunk arising from sudden extension of the scaphoid and lunate alone during the ulnar deviation dissociation from the triquetrum. TFCC tears can also mimic as lunotriquetral instability with analogous injury history and a symptomatic clicking. Provocative lunotriquetral tests are negative, whereas distal radioulnar joint drudge and TFCC provocative tests are positive. In some cases, coincidence lunotriquetral and TFC pathology is demonstrated by arthrography or arthroscopy. Isolated TFCC injury is best visualized by MRI or arthroscopy. Our third differential is ulnar impaction syndrome. It is a result of excessive ulnar positive variance. Pain and weakness with rotational motion are noted. A standard neutral PA radiograph will demonstrate ulnar positive variance and kissing degenerative cyst and sclerosis at the lunate and ulnar head. Lunotriquetral and TFCC tears are frequently associated findings. Arthrography and arthroscopy can assess lunotriquetral and TFCC integrity prior to undertaking an ulnar shortening procedure. Another differential is a pisiform fracture, which may present after acute hypothalamic trauma. This is best visualized by the supination oblique or a carpal tunnel view radiograph. Radial ulnar deviation may be painful, but specific lunotriquetral provocative tests are negative. Pain and crepitus may be found by pisiform compression and translation. Our differential is subluxation of the extensor carpi ulnaris tendon, which produces audible snap as the forearm is actively supinated with the wrist flexed and ulnar deviated. Lunotriquetral provocative maneuvers are negative in that case. As in our case, lunotriquetral instability was the diagnosis. Lunotriquetral instability results from disruption of the dorsal and the palmar and dorsal lunotriquetral interosseous complex. A spectrum of pathology is possible, proportional to the magnitude and equity of the ligamentous disruption. Degenerative membranous perforations may be asymptomatic. Partial tear of ILT membrane may produce dynamic instability, and complete ligament dislocation may produce a static VC pattern. Lunotriquetral instability may commonly follow a specific injury. Hyperextension at the wrist is a common mechanism. Weakness and a decreased range of motion are usually present. Pain is precipitated with radial ulnar deviation, and sometimes a clunk is audible. The individual may perceive instability or a giving way sensation. Ulnar paresthesias are occasionally present. Point tenderness is located at the lunotriquetral junction. A painful clunk may be palpable with radial ulnar deviation. A diminished grip strength and radiocarpal motions are found. 3 provocative maneuvers for lunotriquetral instability have been described: the compression test, the ballotment test, and the shear test. Compression of the triquetrum in the ulnar snuff box using a radial deviated force may elicit pain, suggesting lunotriquetral or triquetral pathology. Ballotment test of the lunotriquetral ligament is performed by grasping the piezotriquetral unit between the thumb and the index finger of one hand and the lunate between the thumb and the index of the other hand. An anterior-posterior translation motion is performed between these bones. Pain and dorsal palmar laxity greater than on the opposite side signifies positive test. A shear test is performed with the elbow supported and the hand on the table and the forearm in neutral position. The examiner contralateral thumb is placed dorsally over the lunate and the ipsilateral thumb loads the piezotriquetral joint from the palmar side. The test is positive when pain, crepitus, or abnormal lunotriquetral mobility is elicited. Comparison is done with the contralateral side for all these provocative tests. A variety of imaging studies can be support a diagnosis of lunotriquetral instability. The standard anterior-posterior radiograph can be normal in partial tears. Findings is incomplete dissociation include disruption of Goulet's arc, proximal triquetral translation, and lunotriquetral overlap. Unlike scapholunate dissociation, a widening of atrocious interval is never visualized. Positive ulnar variance should be noted. When present, it may be cause of additional lunotriquetral tear and require treatment. Arthroscopy has both diagnostic and therapeutic value. Direct inspection of and palpation of lunotriquetral ligament, TFCC, capsular structures, and articular surface allows accurate diagnosis of lunotriquetral pathology. Mid-carpal arthroscopy is important for the assessment of lunotriquetral instability. The treatment of LT is based on severity and chronicity of the injury. Initial management of acute lunotriquetral tear or a partial membrane injuries consists of cast immobilization, which incorporates supplemental padding under the pisiform. Partial lunotriquetral injuries may heal in this fashion. Symptomatic chronic tears and all dissociations or complete membranous disruption, regardless of chronicity, are best managed surgically. The lunotriquetral stability can be restored by ligamentous repair, reconstruction, or arthrodesis. Additional procedures may be necessary if significant ulnar variance or arthrosis is present. Ligament repair at LT is a technically demanding procedure. A dorsal approach between the fourth and fifth compartment and a transverse capsulotomy distal to the TFCC exposes the lunotriquetral articulation. The remaining lunotriquetral ligament is typically adherent to the lunate. The radial portion of the triquetrum is freshened and 3 or 4 parallel drill holes are placed in the ulnar to radial direction. Non-observable suture is passed through the drill holes and anchored to the LT remnant and passed back through the holes. The joint is reduced and fixed with K-wires. Proper alignment is confirmed radiographically before the sutures are tied. The sutures are then tightened. The dorsal radiotriquetral ligament may be advanced and tightened during closure for augmentation. 8 weeks of cast immobilization and 4 weeks of splint immobilization is recommended postoperatively. A reconstruction can be also performed when insufficient lunotriquetral ligament is available for primary repair. A distally based strip of ECU or a FCU is harvested. Static deformity should be reduced and provisionally fixed before preparation of lunate and triquetral tunnels. A K-wire is drilled from the dorsal ulnar corner of the triquetrum to the volar radial corner of the lunotriquetral joint. A second K-wire is placed in the lunate from its mid-dorsal radial border to exit at the same place in the lunotriquetral joint. After radiographic confirmation, the holes are serially enlarged with all. The tendon graft is then passed through the triquetrum and lunate. Lunotriquetral joint is then percutaneously pinned and again confirmed radiographically. Before the free tendon edge is tensioned and sutured back onto itself. Postoperative immobilization is similar to that of other ligamentous repair. Arthrodesis of LT joint is performed also through the dorsal ulnar approach. After the joint surface are decorticated, an intercalary cortical cancellous bone graft is inserted to prevent narrowing of the midcarpal joint. Provisional K-wire fixation and a radiographic confirmation precedes definitive fixation with a compression screw. High non-union rates are reported with K-wires alone or conventional cortical screw. A scaphoid screw is also recommended sometimes. One controversial point is that LT arthrodesis is technically less demanding than ligamentous repair or reconstructions. Reports have demonstrated problems with delayed union, non-union, impaired radiocarpal motion, and ulnocarpal